Hello, everyone. Welcome back. Chatting more with my wonderful doctor. Today, we're going to talk about all the testing that goes into fertility treatments and whether or not you have a diagnosis of infertility, whether or not you need these tests, what these tests are, and all of that good stuff. So, introduce yourselves if people don't know you.
Hey everyone, I'm Dr. Jenny Nichols, and we're going to talk a little bit about, so you've come in and said we have a goal of getting pregnant. What testing do we do, or why do we do that testing? So the benefit of a same-sex couple is I tell couples that you don't necessarily have that diagnosis of infertility. And so why do we do infertility testing? And the explanation I have is, you don't want that diagnosis of infertility, but what happens if we are trying to help you get pregnant and maybe doing inseminations or working to help you get pregnant and maybe done a few inseminations, and now we're saying, well, why are you not getting pregnant? And the downfall is, what happens if you're not getting pregnant after a few inseminations? And now we're saying, well, maybe we should check the fallopian tubes, or maybe we should check your uterus, or maybe we should check to make sure your ovaries are functioning well and acting your age. You would not like us very much if we then say, well, you have a blocked fallopian tube, or hey, you have a polyp in your uterus, or your ovaries aren't acting your age. Then you'd say, why the heck did you not check that 3 months ago? Right. And you know what? We would say, yeah, you're right. We really probably should have. So by the time you reach it in the kind of the world of our fertility world, the answer is we should be checking your ovaries to make sure they're functioning well, your fallopian tubes, and your uterus.
Right. Yeah. I mean, it's
so
I thought
that's
it was kind
why
of
we do and kind of justify the testing.
Right. I think there's a benefit of like, hey, I'm going to make sure that I have the best chance of getting pregnant. And we found a cyst on my ovary. I think I might have had a polyp in my uterus at one point. It's like there's things that you have no idea that you're like, hey, well, maybe it wouldn't have caused a problem, but hey, that polyp could have caused a miscarriage. And, we wouldn't have known otherwise unless we, stuck a camera up there. Good times, everyone. So what are the standard tests that you would do for a lesbian couple if they came in?
Yep. So now one of the things we do say is we say there's nothing saying you can't decline these tests. As long as you understand that if you proceed ahead with an insemination, that if you don't get pregnant, I'm on my phone, that if you don't get pregnant, that we then do the test, that you understand that if we find something, you took that risk of declining the test. So when a patient comes in for that new visit, we kind of explain, hey, what are the testing? And we're going to check ovarian reserve. We're going to make sure that your ovaries are functioning well based on your age. And the ovarian reserve testing includes blood work and an ultrasound. We're going to check kind of the old ovarian reserve test. That's kind of the well-known ovarian reserve test is the day 3 FSH. We do blood work on day 3 called the FSH, or the follicular stimulating hormone. The downfall is it's really key to day 3 or plus or minus a day. And it's really variable. So although, yes, we still do it, one of the better tests is called anti-Müllerian hormone, or AMH. And that is not variable today, and it can be drawn anytime. And that AMH level really shows us, it's not showing us what your likelihood is of getting pregnant, but it's just kind of showing us the reserve of your ovaries. And just giving us a gestalt idea of kind of how well your ovaries, it really shows us how well your ovaries would function if we wanted to stimulate a woman in relation to IVF, but it kind of gives us an idea of kind of the reserve of the ovaries. Okay, I give everyone the warning before I pull a uterus model into the picture. Ta-da!
I've seen
and I joke that this uterus has pretty much everything wrong with it. But so we want to show how the ovaries are functioning, but then we also want to show the fallopian tubes and want to make sure that they're open. And we want to make sure that the uterus is normal, because obviously in order for a woman to conceive, We want to know that the ovary can release an egg, and that egg travels down the fallopian tube. And while the egg is in the fallopian tube, we want to know that if we were to introduce sperm into the uterus, that it can travel down the fallopian tube and meet that egg. And that that embryo, once it fertilizes, can continue to travel down the tube into the uterus and implant into the uterus. Now, in the uterus, we want to make sure that that embryo has nothing that would affect it. So we want to make sure that that embryo doesn't have any polyps or fibroids inside the uterus. And this uterus has absolutely everything wrong with it. But we want to make sure that that embryo could implant into the uterus and that there's no polyps or fibroids. So what other testing do we do? So pretty much what we're doing is when a woman gets her period, we're bringing her in around day 2, day 3, day 4 of her cycle, and we're going to do an ultrasound. And we're going to look and make sure that her lining is thin and that it's not too thick, giving us a sign of polyps or anything else abnormal in that cavity. And then we're doing an ultrasound to look at something called her antral follicle count on her ovaries and show us the reserve of her ovaries and how her ovaries look. Looking to make sure she doesn't have any cysts on her ovaries, that anything else doesn't look abnormal on those ovaries. And then doing that day 3 FSH. And if it hasn't been drawn already, we're checking her anti-Müllerian hormone. And then what we're going to do is we're going to schedule her tube test, her fallopian tube test, and her uterus test. And the fallopian tube test can be done one of 2 ways. It can be done as an X-ray test, but more commonly, frequently now, it's done as a saline test. It's easier to schedule, sometimes a little less crampy, but what we usually more commonly do now is a saline tube test that's done in the office, and that is done in between days 5 through 12 of the cycle before a woman ovulates. So for the tube test, in between days 5 through 12, what we do is we put a speculum into the vagina, and we put a teeny little catheter, I'm trying to center it, into the cervix, and we put a bubbly salt water up into the uterus, and that bubbly salt water travels down through the tubes, and by ultrasound we can see that bubbly salt water spill out around the ovaries. And so therefore we know that the tubes on both sides are open because that bubbly salt water spills out. So we know the tubes are open. The X-ray test is very similar, just a radio opaque dye, a dye that you can see by X-ray. Would be pushed in, and by X-ray, you can see that that X-ray dye goes through the uterus, through the tubes, and by taking X-rays, you can see that it spills out around the ovaries. So that's the tube test. You're just making sure that by pushing the dye through the uterus and the tubes, that the tubes are open. Clearly, what you don't want to see is that the tubes are blocked. It kind of looks like this. This is an abnormal tube. And that the tube is blocked and fluid filled, and it's kind of, you can see it looks really blocked and kind of blunted, and it's dilated and fluid filled. And that's something called a hydrosalpinges, or a blocked tube. And clearly that doesn't work well, because even if this ovary released an egg, it wouldn't travel down this tube and wouldn't meet the sperm. So yeah. Now the uterus test also is done in between days 5 through 12. And we can do it one of 2 ways. We can also put a catheter up into the uterus and push a salt water, not bubbly salt water, because that bubbly, the key to the bubbly with the tubes is that you can see it by ultrasound, but instead just a plain salt water. And by doing an ultrasound, we can see that cavity. I tell women that normally the uterus kind of looks like this. It collapses in on itself. When we push that salt water, it insufflates it, and you can kind of see like what looks like a little black water balloon by ultrasound filling up. And what we want to do is we want to make sure that there's nothing sticking inside of that cavity like a polyp or a fibroid. And so by pushing in that fluid, we can make sure that that cavity looks nice and smooth all the way around, and there's no polyps or fibroids inside of that cavity. We can also do it with another test during that same time period called a hysteroscopy, where we put a camera into the uterus, and with direct visualization, with a teeny small little camera, can look inside and make sure that there's no polyps or fibroids inside of that cavity. Both tests work perfectly well and make sure that there's nothing in that cavity that would affect an embryo traveling down the tube and implanting. And that's the basic testing. We want to check the ovaries, the tubes, and the uterus in a nutshell.
I had to do the camera one. That one was not a party. I would have preferred the saline one. I'm like, is this
the
new?
downfall, and there's positives and negatives to both. The downfall of the saline one is if you do it and then you find something, you then have to do the other one because you can't remove a polyp if you do the saline one. You know, the downfall of the camera one is it's a rigid camera that goes in. They're both not comfortable. They both have the thing that hurts about them is that the uterus is a huge muscle and it contracts against whatever goes into your uterus. So it just cramps. And really, I use the word contract for a reason. It contracts against whatever's in your uterus. So
we had to do it at a surgery center. So Jordana was put out for that. So you had the choice of going under anesthesia, and she does not like pain. I chose to stay awake. And before I had kids, it was awful. But after I had a vaginal birth and I had to do it before Josie, it was fine. And I remember you telling me that you're like, after you have kids, it's, I don't know, it's
like a mild, short, less than like a minute and a half contraction. It takes really short.
But after having the vaginal birth, I know that you had said to me, and I think other friends did as well, that it was just not as much of a thing. Like, and it wasn't the second time, but the first time was not a party. But again, grateful that I did it because I'm pretty sure I had a polyp. I know Jordana did. I don't remember. That was like a lot of years ago at this point. I think it was 5 years ago.
Yeah, but the testing is clearly worthwhile because you would not want to go through a few inseminations and then say, oh, I had a polyp in there, or, oh, I have a blocked tube, and what should we do differently? Should we consider IVF instead if I have a blocked tube and it would decrease my success? Or, oh, my ovaries aren't functioning well. Should we consider a more aggressive treatment instead of insemination? Or, something like that.
So if we...
And obviously... Oh, go ahead.
No, I was going to say, are these tests
I was going to say...
I
would say that most fertility practices probably think they're pretty worthwhile. I think that although in a young, healthy woman who has no, proven infertility, you may not need to go through them. I think that in a heterosexual couple coming in who has been struggling to get pregnant, obviously we're doing all of these. So we see benefit because we see abnormals in them when we do them regularly. So it makes sense to say, before you're going to be spending money on donor sperm and before you're going to be doing this, it makes sense to make sure everything's normal.
Yeah, it's expensive.
I had the uterus model.
It's all good. We've got one, Yeah, no, I think it's expensive to just try. And then if you're like, oh, I have a cyst on my ovary, I could have had that taken care of months ago. And, I think that what's hard is that when and I said this in another video, but like when you want a baby yesterday, and you're like, oh, well, I want to try this month. And you're like, well, you actually have to wait a few months because we need to test you at this part of your cycle and at this part of your cycle. And it's like, oh, but I just want to try. But if you think of it as you're increasing the likelihood that you're going to get pregnant, hopefully, by doing these tests, then it makes it better and more worthwhile.
Yeah, the testing really does take like one cycle. Okay. And the other thing I tell people is, sometimes we even use a medication if your cycles are irregular to help regulate your cycles. So in that month of testing, we can test how you do on that medication to make sure you feel okay on the medication, your ovaries do okay on the medication, your lining looks okay on the medication. So those medications are sometimes Clomid or Letrozole. So if you have irregular periods, we can make sure you respond okay to that medication. So take it as kind of a test run before you actually do the insemination to make sure you feel okay and you do okay on it. So while we're testing your tubes and your uterus and your ovaries, we can put you in that test run of that medication. So before you even get ready to do the insemination the next month, we know that you're going to respond well to that medication.
Right. And I know that you mentioned in the first video that we did that, if somebody has a really long cycle, you can also bring on a period. So it's not like you need to wait 60 days until your next cycle starts, that you actually can do that, which is crazy.
Yep.
Kind of cool.
Yeah. Yeah. And really, it seems like a long time, but, you know, I'm telling someone, hey, at your first visit, you're going to call us as soon as you get a period, and we're going to do the testing. And that testing is going to come as soon as you get your period, and we're going to do the testing. And then as soon as you get your next period, if the sperm is ordered, and we're ready to roll. And one of the things you're going to learn as you start talking about ordering the sperm is, as we do the blood test, that will help guide you of, hey, how do you know what sperm to order? And we're going to help guide you of cytomegalovirus. Are you cytomegalovirus or CMV negative or positive? And should you be ordering a CMV negative or positive sample? Blood type, you know, Rh negative or positive, although that really doesn't tend to affect whether you order an Rh negative or positive sample. If you're Rh negative, obviously it can decrease your risk of Rh isoimmunization, but really you're getting RhoGAM if you're Rh negative anyway. That goes into a more in-depth discussion, way more in depth, but
yeah, I don't know what those words mean, but cool.
Yeah. We have information sheets that we give patients, but I tell people that, you know, for heterosexual couples, that depending if, you know, that couple is going to tell that the child, if they use donor sperm or not, that, you know, they may order a sample based on what the husband's blood type is, so that they can order a sample based on what his blood type is, so that if they're going to tell that child or not. That's, you know, sometimes the blood type. Now, if a woman is Rh negative and she does have history of an antibody, that may be important too. But for a same-sex female couple who their blood type, that really is not going to change what type of blood type they need to look at. But that blood work that we're doing at the very beginning as we see you, some of that is changing how you order the sperm, you know, samples. So that is good information that we're going to help guide a couple along as we, you know, as we help you.
Yeah, you didn't even think about that. You know, I was like, I just like this person, you know.
Yeah.
But we'll talk about sperm another day.
Whole another discussion.
That's a lot of discussions. But one thing that we had to do, and I know that other same-sex couples have had to do as well, is to see a psychologist when ordering donor sperm. And you and I have had conversations about seeing a psychologist when you order donor sperm. And, you know, one thing I said to you is that, you know, in one way, the community kind of finds it offensive of like, what do I need to see a psychologist? Like, you think it's like some psychological evaluation, but it's really not that. So I know that, you know, your clinic, our clinic.
Not, we've had this discussion. It's not a psychological evaluation. And so I like the term better, psychological counseling. And the reason is anytime we use within our office, donor sperm, donor egg, donated embryo, anything of any donor sort, we require psychological counseling. And just take it as a chance to be able to talk to someone about questions that may arise in the future. And I think you had said questions that you would have never even thought of.
Yeah. I mean, I found it helpful. I think, you know, it was, have you thought about how you're going to tell your children where they came from, about the donor, about whatever, you know, talked about using an open donor versus an anonymous donor, and kind of fitting that in. And what I loved is that the psychologist that we saw suggested creating a story, like even like a bedtime story of like, you know, mommy and mama really wanted you and someone gave us a really generous gift. Like just starting it kind of that way. And then also things you don't think about, siblings, like donor, like diblings, you know, donor siblings, that other families who've used the same donor. How do you talk about that with your kids?
And so as a practice, obviously, it's really hard to distinguish who needs that psychological counseling and who doesn't. And, you know, there may be same-sex couples who say, yeah, we have talked about every single question that this psychologist can bring up to us. And some who say, we have never thought about a single thing and may need it. And then a heterosexual couple who the male partner has azoospermia who has no sperm, and they are really struggling, but they want to conceive and they need donor sperm. But he is emotionally struggling and they've decided to use donor sperm, but it's affecting their marriage and they're using donor sperm. But how are they going to tell their family? Are they never going to tell their family? Are they going to tell this child? Are they not going to tell this child? And we don't know as a practice how they're doing or how they're not doing. And so, having them talk to a psychologist may help them, may help their marriage, may help how they tell that child or don't tell that child. And, the benefit of just including a psychologist in on that couple may help them, may help their future. And so the benefit of including it across the board for anyone who's incorporating donor services, period, is that we don't have to be the deciding factor of who needs it and who doesn't. It's just when you're incorporating donor services, donor sperm, donor egg, donated embryo, gestational carrier, donating uterus, is that then it is across the board. We know that a psychological counseling appointment is required, and then it can be a quick appointment if all the questions are answered and that psychologist says, yes, they've thought about all these things, and it can be a more depth appointment so that, this couple really did require a whole lot more discussion and had a whole lot more concerns.
Right.
And then as a practice, we feel comfortable that we did our part to make sure that concerns may have been answered where we didn't know there were shortfalls or maybe more of a need.
Right. Well, one other thing that we had to do also was genetic counseling. And what's the point of that if there's no history of genetic issues? Yeah.
So even, any couple who enters our doors, we do and recommend, actually require, that one partner gets genetic testing, meaning carrier screening, to make sure they're not a carrier of any genetic diseases. And if they decline it, then we have them meet with genetic counseling. And so I would say that, and it may have changed since you were a patient, but we require that they have genetic testing. So if you are tested and you are not a carrier of any genetic diseases, then you are good. If you are a carrier of any genetic diseases, then we want to make sure that the donor was tested. The problem in the past is that donor panels, it is improving significantly. They're doing bigger panels for the donors. So as time has progressed, the donors are getting bigger, fuller panels done. But in the past, if a woman was a carrier for anything and the donor wasn't tested for that one specific disease, then we required genetic testing so that the couple understood, hey, you are a carrier for this, but the donor may not have been tested for that one thing. And so then genetic counseling was required to say, hey, you're a carrier for this. This is what the ethnic background is for the donor, but the donor wasn't tested for that one thing. Here is their risk of it based on their ethnic background.
Got it.
If maybe their testing wasn't available or no longer available based on when they had donated.
Right. Got it.
So the benefit is their testing has now improved.
Cool. Yeah. We bought our sperm like 5.5 years ago. Really long time. Yeah. All right. Well, this was helpful. I mean, I forgot the timeline of everything, and I just remember a lot of tests, and it also was because we did both of ours and at different times and obviously different cycles. So I was like, is it months that somebody has to wait if they come in and they're, needing to get tested? So it's nice so that people can know, like, hey, it's typically just one cycle. So you're not having to wait forever.
Yeah.
Awesome. Well, thank you for your wisdom and your uterus and all the good stuff. And we will have more info.
My kids know what it is. It's crazy.
It's helpful.